usually through neuronal activity. There is electrical activity that's produced by neuronal discharge. And this electrical activity can be studied with techniques such as EEG, electroencephalography, and MEG, magnetoencephalography. Well, we also know that there's a metabolic response. There's an increase in glucose consumption, for example. And this response can be studied with techniques such as PET, FDG PET, or positron emission tomography. And there's also a concomitant hemodynamic response with an increase in blood flow, an increase in blood volume, an increase in blood oxygenation, specifically in the area of the brain that is active, that when the brain becomes active in response to something. And this can be studied with techniques such as optical impedance tomography and functional MRI, or fMRI. So let's talk specifically about fMRI. And fMRI uses a contrast mechanism, and it's an endogenous contrast mechanism, meaning I'm not injecting anything into the body, and it's called BOLD, or blood oxygenation level dependent. So let's say, for example, we have a blood vessel, a capillary bed going in between neurons. So these are neurons in the brain. And we have a basal state, and at the base state, there's some sort of basal neuronal activity that's happening. There's a basal amount of blood flow. There's basal amount of concentration of oxygenated and deoxygenated hemoglobin coursing through these vessels. And of course, a baseline MRI signal as I'm imaging the brain. Now let's say these neurons in this area become active. And so now there's an activated state of the brain. And there's an increase in blood flow. There's an increase in oxygenated hemoglobin. And also then, by ratio, a decrease in deoxygenated hemoglobin in this part of the brain. This decrease in deoxygenated hemoglobin is actually the important part of this contrast mechanism because that serves to lower the localized field gradients, and we're talking about MR field gradients now, magnetic resonance field gradients, around these blood vessels. And that, in turn, increases the MRI signal from the lower field gradients. So to summarize, an increase in activation leads to an increase in this ratio of oxygenated to deoxygenated hemoglobin, which then leads to an increase in an MR parameter called T2 star, and that increases the MRI signal. So what does data look like? So here's a brain, and let's look at one location in the brain. These locations are called voxels. So you maybe have heard of pixels, but these are voxels for volume elements. And let's look at the MRI signal, which is just the brightness. Let's say I'm taking a snapshot picture of the brain, and let's look at that brightness over time. So here's time on the x-axis over here, and here's the MRI signal on the y-axis. And basically, I'm collecting a picture of the entire brain every 2 to 3 seconds. And so this, I have data from this location, MRI signal intensity from this location, which is now changing over time. And in this case, let's say, for example, I take an acupuncture needle, I put it into the body over here, and then during prescribed times, I start stimulating that needle. So I'm twirling the needle over here, then I stop twirling, then I'm twirling the needle over here, then I stop twirling. And I look to see, I'm asking the question, how does the brain respond to this stimulation? And so the next part is just doing a statistical test everywhere in the brain, in every location of the brain, to see where the MRI signal, which is over here, is statistically matching the stimulation paradigm. It's called a stimulation paradigm or a block design. And so that's when you see these beautiful pictures of brains with colors over top of them, all you're seeing is the results of a statistical test. So these are locations where there was statistical significance for a time course, an MRI time course, that matched the stimulation block design paradigm. And you can have activations where the MRI signal is increasing every time I'm doing something, and you can have deactivations where the MRI signal is decreasing every time I'm doing something, meaning that the brain activity in this area is actually higher when I'm not doing something, when the subject is resting, than when they're doing some sort of task. Okay, and so this is basically just the results of a statistical test that can be overlaid. And we have, we have these kind of data for all through the brain. I'm just showing you kind of what's called the mid-sagittal slice, directly centered around the brain. And we have this data for everywhere in the brain, basically. So how can we now apply neuroimaging to study potential brain mechanisms by which acupuncture might be working for different conditions, different pain conditions? So this first part of the talk is going to be about neuroplasticity in carpal tunnel syndrome treated by acupuncture. So carpal tunnel syndrome is a localized condition, a very focal lesion that's located basically in the wrist. It's the most common, quote-unquote, entrapment neuropathy. So this is a neuropathic pain condition, I would say, relatively high US prevalence, or prevalence around the world, really. So, and there's a vicious cycle of CTS, or carpal tunnel syndrome. And you can start anywhere along this cycle, but basically at some point there's an increase in pressure inside the carpal tunnel. And here's the carpal tunnel. Here's the nerve, the median nerve running through the carpal tunnel. And so there's an increase of pressure inside this tunnel, leads to ischemia and inflammation, which then damages the nerve microvasculature, leading to exudative edema and fibrosis, which then itself circles back and serves to increase the pressure in the carpal tunnel even more. And so we go around and around the cycle, unfortunately for the patients. And the symptomatology, all of this leads to pain, but not just pain, also paresthesias in digits or fingers innervated by the median nerve. And that's the first through the fourth digits. Okay? The ulnar nerve is what innervates the pinky, the fifth digit. So in this study, this was a pilot study that we ran a few years back. Subjects were evaluated with, patients were evaluated with clinical testing, fMRI with sensory stimulation on 3 fingers. 2 of these fingers, 2 and 3, are innervated by the median nerve, and digit 5 is innervated by the ulnar nerve and served as somewhat of a control. Then these subjects went off for 5 weeks of acupuncture, treated in a longitudinal course of acupuncture. They were tested clinically halfway through, and then they came back at the end of the protocol and were tested again with clinical testing and fMRI after this 5 weeks. The fMRI stimulation that was used was innocuous 100 hertz electrostimulation on these 3 fingers, pseudo-randomized in order, and just below the pain sensitivity threshold. So it was strong stimulation, but it was innocuous, meaning it was non-painful. We're just trying to map how the brain responds to stimuli coming from these fingers, okay? I'm not going to get into details of that. And we also had a control group of healthy adults who do not have carpal tunnel syndrome. This was documented with clinical testing at baseline. They also performed the same exact fMRI evaluation. Then they sat around for 5 weeks, and we brought them back for clinical testing and fMRI after this 5-week wait period as well. So the acupuncture protocol was quote-unquote semi-individualized protocol. There's this sort of natural tension in the acupuncture research community where on the one hand, you want to choose a protocol that's reproducible, and so everybody gets the same thing, so you're trying to really evaluate a specific protocol. But on the other hand, that's not really how acupuncture is practiced in the clinic. So in the clinic, there's a certain diagnostic procedure that happens, and acupoints are chosen based on this diagnostic procedure. And so we tried to kind of walk the fine line there in this study by having a semi-individualized protocol where there's some common points that everybody gets, which is electroacupuncture from these 2 acupoints, pericardium 7 and triple warmer 5, that are basically right here on the wrist and right here on the dorsal aspect of the forearm. And then there was variable points that were chosen by the acupuncturist that was based on the individual presentation of exactly where the pain is in these patients. And so they were treated for 3 times a week for 3 weeks, and then 2 times a week for 2 weeks, for a total of 13 treatments over 5 weeks. And the results were as follows. This is quote-unquote subjective results. Patients are now reporting how much pain and paresthesias they had, how bad were their symptoms, and the red bar is the baseline score. And then this is the midway through. They were also evaluated, the orange bars. And we found statistically significant improvement midway through the acupuncture protocol, and even more so by the end of the protocol in these patients. But one kind of nice thing from a research standpoint about carpal tunnel syndrome is that we don't just have objective scores of how bad is your pain. We also have objective scores. Sorry, we don't have just subjective scores. We also have objective scores, which is from nerve conduction testing that was performed at the clinical evaluation. So here we're actually measuring the speed of a electrical impulse over the median nerve. So you stimulate sort of proximally to the lesion, and then you see how long it takes for this impulse to get distal to the lesion on different fingers. Okay? And what you can see, so the red bar is the baseline in the patients, and the blue bars is in the healthy controls. You see a huge difference, and this is basically what makes a carpal tunnel syndrome patient a carpal tunnel syndrome patient, is basically being positive on this testing. So you have a really profound slowing of this impulse, of the velocity of this impulse over the carpal tunnel. And the yellow bars is after the acupuncture protocol. We saw not normalization, but we did see statistically significant improvement in these nerve conduction velocities after the acupuncture treatment. So we also found some evidence of improved functional improvement. This was in grip testing. So these are now change scores relative to baseline. There's a wide variability between subjects in what somebody's maximum voluntary contraction is. And so we look at change scores in this case. And so we see change scores midway through was not very different in the patients, but after the acupuncture protocol, there was a nice improvement in the grip strength in the patients, no change in healthy adults as well. So how about the brain imaging results? So this is now the brain response to stimulation of one of the median nerve innervated digits or fingers. And you can see, so in this case, the finger that was being stimulated was on the right side of the body, or for subjects where the lesion was on the left side, we actually flip the brains or flip the data to make them equivalent. And so what we see then is contralaterally on the left hemisphere, so this is the left hemisphere of the brain, and this is a slightly different representation where we use a software tool to inflate the brain. So instead of having activations and deactivations kind of hiding in the valleys and only being able to see them on the top of the mountaintops of the gyri, we've inflated the brain, and so now we see both the sulci, which are the valleys, and the gyri, which are the mountains, and we can pick up all the activations, just a nice way to visualize the data. And so what we see here is in healthy adults, there was a nice activation contralaterally in the contralateral hemisphere in a part of the brain called S1, or the primary somatosensory cortex. We also saw activation in both hemispheres in S2, or the secondary somatosensory cortex. And we actually saw some deactivation on the ipsilateral side, or the same side that the hand was being stimulated on, also in S1, or primary somatosensory cortex. And this is all very normal. This is very well known, very well understood. You don't just activate, opposite in the brain hemisphere opposite to the stimulation side. You actually deactivate on the same side, on the ipsilateral side. And this is just our brain's way of focusing its attention on the stimulation that's happening from this hand. We want to ignore what's happening on this hand because something important is happening on this hand. And what we saw in the carpal tunnel syndrome patients was that there was some degree of hyperactivation, or an increase of activation in the contralateral S1, or contralateral primary somatosensory cortex, and perhaps some evidence of a decreased deactivation ipsilaterally as well. So, and this is not unusual in other chronic pain conditions where there's a disinhibition that's happening in the brain. And so there's a hyperactivation in response to sort of an equivalently produced stimulus. And I'll show you this to you in fibromyalgia as well a little bit later. So what happens after acupuncture? This is, again, for digit 3 stimulation. For whatever reason, we didn't see this for digit 2 stimulation. But for digit 3 stimulation, which is also median nerve innervated, we saw a decrease in hyperactivation, a more focused representation in primary somatosensory cortex. After this is the same exact patients, but now being studied after the acupuncture. So another interesting thing that we wanted to look at is what's called somatotopy, or not just how much activation is there contralaterally in S1, but where is that location? Where is the location of that activation? And so maybe you've heard of the homunculus, or the little man on the brain. So this is kind of the mapping. This mapping was actually done in Canada by a surgeon named Penfield in the 1930s, where he was studying patients, I believe, with epilepsy, and had access to the brain and took an electrode, and the patients are awake, and he would stimulate different parts of S1 and ask the patient where they felt that stimulation. And by doing this, a very long time ago, he was able to map out the homunculus, or S1. And so you can see here's the face area, then the hand area. And it's interesting to note, here's S1, by the way, in the postcentral gyrus. This is the central sulcus. And it's interesting to note that this map is, quote unquote, distorted, where there's a lot more cortical territory for the face and the hand than there is for other parts of the body. And this just basically reflects our sensitivity. We are much more sensitive in the face and in the hands than we are, say, in our back. So we just don't need that many neurons to process information coming from our backs as we do to process information coming from our hands and from our faces. And this happens in development. So for this study, we're very focused on the hand. So this is the location of the hand in the S1 homunculus. So this is just looking at how can fMRI be used to map this. So this is in a single subject, activation contralaterally for stimulation of digit 2, digit 3, digit 5. And yes, there is overlap, but I would ask you to agree with me that if I looked at the sort of the center of mass of these activation clusters, you can actually see it translating medially or superiorly along this gyrus from digit 2 to 3 to 5. And if we go back to the 1937 description from Penfield, we actually see that the way he mapped this out, or the way he produced this, is from thumb to index to middle to ring to pinky up the gyrus. And so the whole point is just I'm trying to convince you that we can use fMRI as a non-invasive tool in awake behaving humans to look at S1 somatotopy. So what happens in carpal tunnel syndrome patients? So this is healthy adults on the top. This is the center of mass of the group activations for digit 2, digit 3, and digit 5. You can see a nice separation between these digits as they translate up the gyrus. And contrast that with the results for carpal tunnel syndrome patients. Digit 2 and digit 3 are much closer together than they are to digit 5. And so these are the two median nerve innervated fingers. And this, coupled with the fact that there's sort of hyperactivation happening, basically our interpretation of this is that there's a blurring. The digits are no longer as separated as they are in healthy adults, and there's now a blurring of these digit representations in these patients. And what we found is that after this 5-week period, the healthy adults still have relatively nice, as you would expect, a relatively nice separation of these fingers. And in the CTS patients, we definitely get more separation of these fingers after improved symptomatology and after the acupuncture therapy. So we then look to see if there's any correlations between this. And so now we're trying to correlate the improvement in median nerve sensory latency on the x-axis with, this is now the baseline data. So at baseline, our patients who are worse, our patients who have worse median nerve latencies, also the ones who have more blurring. And that in fact appears to be the case. So median nerve latency is on the x-axis, so the higher the number, the worse the peripheral pathology, the worse the slowing is of this impulse. And on the y-axis is an fMRI measure of the separation distance in that patient from digit 2 to digit 3. And we see that the worse the pathology, the closer this number is to 0, the closer we are to basically a blurring of these two digits. And now this is what I was talking about previously. This is the change scores. So is an improvement in median nerve sensory latency also associated with an improvement in the separation distance? And we do have evidence to that fact. So these are, quote unquote, the non-responders here on the right, the ones where there was not a big change in median nerve sensory latency. And on the left are the responders, the patients who do have more response in improvement in median nerve sensory latency. And the ones who improved the most were those subjects, the patients who had the greatest change in separation distance from D2 and D3. So our model for this is that in CTS, there is a central manifestation or a brain manifestation of the peripheral nerve dysfunction. CTS is not just a disease of the wrist. There's also concomitant change in the brain, neuroplasticity, if you might call it. So there's pain and paresthesias. These are the symptoms of carpal tunnel syndrome, lead to more frequent and abnormal nerve traffic to the brain. which then through disinhibition leads to more extensive and wider digit representations in the cortex. But it's not just more frequent in abnormal nerve traffic. The paresthesias, the dysesthesias in carpal tunnel syndrome are diffuse, meaning the patients feel kind of this tingling diffuse over the parts of the hand that are innervated by the median nerve, the first through the fourth digits. And so because these paresthesias are diffuse, it's more simultaneous signaling from the affective digits. So instead of, when you manipulate an object, when I take a pen and I manipulate it, there's a temporal break between when my second finger feels it versus when my third finger feels it. And that's what produces the separation in contralateral S1 of these finger representations. In this case, it's a more simultaneous signaling from the affective digits because of all these paresthesias. This simultaneity, through something called Hebbian plasticity mechanisms, then leads to less separated and blurred digit representations in the cortex. And that's our model of what's happening in carpal tunnel syndrome. So one interesting thing is we wanted to look at was there a relationship between the improvement in paresthesias and the improvement in somatotopics, so specifically with the paresthesias. Again, this was a pilot study with very small numbers, but we have some evidence that the patients who improved the most in paresthesias were the ones who increased their D2, D3 separation distance the most. So we're following up on this promising preliminary data. And one question I think that's important to ask is, well, who cares? What is the behavioral correlate of having your S1 be blurred, of having a blurring of D2 and D3 fingers in contralateral S1? Well, one question is this sort of the brain mechanisms that are underlying a phenomenon called finger agnosia, or not being able to, let's say I blindfold these patients, I stimulate their second finger, and then I ask them, which finger did I just stimulate? Are CTS patients more likely to misattribute D2 stimulation to D3 and vice versa because they have a blurring of these digits in S1, and so they're not able to tell the difference? And you can imagine some of the functional implications of this, and one of the problems that these patients have is, for example, very fine motor control of their hands and being able to say, pick up a teacup. That's the classic example, is not being able to pick up a teacup with their hands because of this lack of fine motor control. So that's something that we're following up in our next study that we're in the middle of right now. And so here we have CTS patients that are now randomized to 3 different groups: a local varum acupuncture group, which is what we had in the pilot study, a distal varum acupuncture group. Is it just important to have acupuncture, or does it matter where exactly the acupuncture is happening? And then a sham acupuncture group, where here we're using a Streiperger needle, which is a device that looks like an acupuncture needle but doesn't actually penetrate the skin. And one thing that's kind of was interesting, we're a few years into the study now, is that how hard it was to recruit these patients. And so a lot of people think they have carpal tunnel syndrome, but they don't. They have what's called idiopathic hand pain. And so we bring them in, we evaluate them with clinical nerve conduction testing, and their nerve conductions are fine. But they still have this pain. You can't tell them, no, you don't have your pain just because your nerve conductions are fine. They have idiopathic hand pain. And so we had so many of these patients that we decided to open a new group in our study. And so we're treating them now as an interesting comparison control with true CTS patients with varum acupuncture, and we're going to have interesting comparisons there. So we have several questions we want to answer here. For example, is varum acupuncture better than sham acupuncture, and by which brain mechanisms? Is local acupuncture better than distal acupuncture, by which brain mechanisms? Is there a behavioral correlate to maladaptive S1 plasticity? And what brain mechanisms might underlie patient response to sham acupuncture? These are all important things to answer. And so this is some of sort of like the unblinded data. So we have a decent number of subjects now, and we're working up the kind of the baseline measurement data now, just to look at some of our measurements, and it's actually been very promising. Now this is a much larger population. We have in this analysis, I think we have even more now, but in this analysis there was 22 healthy controls and 27 patients, and we still see a diminishment of the D2, D3 separation distance in contralateral S1. And this is very important. This is a completely different, we actually are using different procedures here, completely different patient population, and our neuroimaging biomarker, if you want to call it that, is consistently decreased again in the patients. And this is also very interesting. So now we do this test called a 4-finger forced choice response task, where we've built this system that has piezoelectric vibrotactile stimulators for each finger, actually each of 4 fingers. And so the subject is sitting there. They don't need to be blindfolded. They place their fingers on each of these holes, and they're just told that at some point, one of those fingers is going to be stimulated with a vibration. And once you feel that, you have to tell us which finger was being stimulated. And by doing this test, we can then see how many times they get it right. And we can see how many times they get it right for D2 and D3, the median nerve innervated fingers. And we, in fact, while this test is actually fairly easy, so the correct rate is fairly high, I think we've made it just barely, I think, hard enough that we are seeing a statistically significant difference in the correct rate. So this is 100% correct over here, and the healthy controls are responding with a higher correct rate, as we hypothesized, than the CTS patients. And so what we want to do now is try to correlate that with a D2, D3 separation distance. That would be a really interesting and, I think, a powerful test. So moving along to part 2. What happens, what might be potential acupuncture mechanisms when the lesion is not local, such as in carpal tunnel syndrome patient, but is more global? And in this case, we're looking at a pain condition, a chronic pain condition called fibromyalgia. This is basically reported as, can be whole body pain of unknown origin. There's been a lot of controversy with this type of chronic or functional pain condition. It's called functional pain because we don't know exactly where the lesion is. I think a lot of researchers are basically making the push that the lesion is actually in the brain, and that a lot of, not just fibromyalgia, but TMJ and a lot of quote-unquote functional pain conditions are actually diseases of the brain. And so neuroimaging is a very interesting way that we can look and see how the brain function in these patients differs from healthy adults that don't have this condition. So this, for example, is what's known as sort of an evoked pain study. You're looking at hyperalgesia. It's known that these patients report pain as being stronger than a comparison group of healthy adults when stimulated with the same amount of pain. And so these are sort of the brain correlates of this quote-unquote hyperalgesia. And you can see the insula is an important area that shows greater activation in patients than in healthy controls when they're being stimulated with a quote-unquote experimental pain. So this is not their endogenous clinical pain. This is an experimental pain that's being induced on these patients. And these are the regions of the brain that are hyperactivating to that pain. So both in pressure pain, both in heat pain, multiple studies have shown this phenomenon of hyperactivation in areas such as the insula. Now the question is what are actually the brain correlates of the clinical pain? Hyperalgesia is a very important phenomenon in these chronic pain patients, but what are the brain correlates of their actual clinical pain? This is something that is very difficult to study with conventional, traditional neuroimaging methods. And so a lot of neuroimagers are trying to approach this question and trying to get at what are the brain regions that are actually supporting the clinical pain. So for this, our group and I think some others are making the contention that we need to look beyond the evoked fMRI response. And we need to look at connectivity, maybe referred to as a social network within the brain. So the brain works not just by evoked response in discrete areas, but also through connectivity between different areas. And this has been termed the connectome. Okay? So how are different parts of the brain connected to one another? So one way to look at this is with resting state connectivity, which assesses intrinsic brain networks. So in this type of evaluation, which I'll describe in a second, we're looking at how is the brain connected at rest. So why? Well, the brain is 2% of our body weight, but actually consumes 20% of our bodily energy. Task-related increases in the brain in metabolism is actually quite small, less than 5% when compared to a very large resting and much less studied energy metabolism. So this is kind of the analogy of the iceberg. The evoked response is kind of what has been studied a lot with conventional neuroimaging, but how can we look at this intrinsic activity, this connectivity within the brain using neuroimaging? So one way that people have started to grapple with is using fMRI, or functional MRI. And fMRI fluctuations at rest are not random or chaotic, but instead correlate across network-specific distant brain regions. And this is a very interesting phenomenon. You can see here, this is a time-lapse movie of activity within the brain. And you can think of the fMRI signal as basically fluctuating up and down. And when it's up, it's being color-coded as orange and red. And when it's down, it's being color-coded as blue and cyan. And what you can see is that these fluctuations throughout the brain are not random. You can see patterns. You can see that when some regions of the brain become active, other regions of the brain that are specific to that region also become active. There are these networks within the brain that are co-activated and whose activity fluctuates. They're sort of synaptic, thought to be synaptic neurotransmission and connectivity in these areas of the brain when we're just sitting there doing nothing, thinking about nothing, or maybe thinking internal thoughts, and not responding to some sort of evoked task or evoked stimulus. So this phenomena, it's got a very interesting history how this started to be studied. And it actually dates back to almost around the birth year of fMRI itself. So fMRI was more or less invented in 1991, 1992. Just a few years later, there was this very interesting study, actually I think from our center by Bharat Biswal, that looked at resting state connectivity. And what he did is he did this really interesting experiment where he had the subjects go in and he took resting data. So the subjects were just lying in the scanner, just thinking about nothing. They were told to think about nothing. And the brain, who knows what they were doing, the brain was scanned for 6 minutes, or it might have been 5 minutes here. And then the subject was told to perform a motor task. And this is a very common task at the time where they're just told to tap their fingers back and forth in one hand. And this is the brain response to this motor task. Now, Bharat was very worried that if the subjects knew what they were going to be doing, they might be thinking about a motor task, and he didn't want that to influence the results. So he didn't tell them anything about what they were going to be doing. He just told them to go into the scanner and do nothing, and then he told them, now you're going to do a motor task. As it turns out, it actually doesn't matter. Whether you tell them or you don't tell them, you'll get the same result. And so then what he did is he took the results of the motor task. This is the primary motor cortex. He took a seed within one of the activation clusters in M1, and then he went back to the resting data. He put that seed in that data and asked the question, where else in the brain has a signal that's correlated to that seed? And what he found is that he was basically able to replicate the brain response to the motor task with just the seed connectivity in a resting state. And this was actually a very fascinating observation that was dutifully ignored for about 10 years. And then, well, I shouldn't say that. There was a few studies here and there over the course of maybe 10 years. And then this whole phenomenon basically blew up in the mid part of well, I guess it's the last decade now. And then there was this other very interesting phenomenon that was kind of parallel to this, something called the default mode network, which is a network of brain regions which was observed to be deactivated almost every time there was some sort of externally focused task. So whether you're doing a visual task, an auditory task, a somatosensory task, a motor task, this part of the brain will actually deactivate it when specific parts of the brain will activate. So it's a visual task, you'll activate your occipital lobe. If it's a somatosensory task, you'll activate S1 again, as we talked about. But the parts of the brain that are deactivated are the same. It's in this default mode network. So it's an anatomically defined brain regions, more active at rest, internal focus, when people are maybe thinking something amongst themselves, versus during externally focused tasks. And it's one interesting question is when are these brain regions actually activated? And what's been found is in cognitive research that this part of the brain is activated in tasks that are related to self-referential cognition, autobiographical memory, et cetera, et cetera. So when we're thinking, kind of internalizing our thoughts, thinking about ourselves, that's when this part of the brain is active. And this part of the brain to be a little more specific here, is the inferior parietal lobule, the posterior cingulate cortex, precuneus, and medial prefrontal cortex. So here's the PCC, the posterior cingulate, and the medial prefrontal cortex. And so that was a very interesting observation back in, I think, 1997 by Schulman et al. And then what was, to kind of tie this back with what I was talking about before with resting state connectivity, it was also found that there's quite a bit of resting connectivity in this network also. And it's actually quite robust. So we see here, this is data from Fox et al., 2005, the yellow time course. So this is now time on the x-axis, MRI signal or bold signal change here on the y-axis. And here's the fMRI signal. The yellow is in the posterior cingulate cortex, and the orange is from the medial prefrontal cortex. You can see it's almost like right on top of itself. Very strong correlation between these two brain regions in a resting state. So now we're asking the question is, how can this be applied to pathology? And right now there's a real, I think, explosion happening with using resting state connectivity to explore pathology, to explore different patient populations. One reason is because it's so darn easy to get this data. And it's so powerful because you can look at children, you can look at unconscious, you can look at so many different states, and this is being applied across the world, all over the place, to all kinds of different pathologies, including, I think, starting to become for chronic pain as well, which is my interest. So in this study, we looked at healthy controls, healthy adults, that were studied with 6 minutes of resting state fMRI, and compared them to fibromyalgia patients that were also studied with 6 minutes of resting fMRI. And in these patients, we also asked them, how much pain do you feel at the time of this scan? And that's very important. We then sent these folks off for 4 weeks of either verum or sham acupuncture, brought them back for 6 minutes of resting fMRI. And the first thing I want to show you is a comparison between groups of fibromyalgia patients at baseline versus the healthy adults. And so in this study, what we found is that the default mode network has greater connectivity to parts of the brain that are known to be responding to evoked pain, and also are known to sort of underlie hyperalgesia in fibromyalgia patients. So we have greater connectivity in the anterior and mid-insula to the default mode network, okay? And we also found that there was greater connectivity in a network called the executive attention network, or it's being called the frontoparietal control network, on the right side in patients versus healthy adults. And this was not the case for other networks. So here you see this was our control, the middle visual network or medial visual network, kind of the primary visual network. You can see that this network was not found to be statistically different between the patient population and the healthy adult group. Okay. So what was, I think, really interesting in this data was that the amount of pain that the patients were feeling at the time of the scan was correlated to default mode network connectivity to the insula. So we know that in fibromyalgia, their pain will fluctuate. It fluctuates spontaneously. And so if we look at when the pain is higher versus when the pain is lower, so this is an inter-subject comparison, inter-subject correlation, in patients who had higher amount of pain, they also had a higher amount of default mode network connectivity to the insula. And so what do we think this means? Well, the default mode network is associated with self-referential cognition. The insula is commonly activated by pain stimuli, supports hyperalgesia in fibromyalgia patients, and is thought to integrate subcortical homeostatic information, example pain, into higher order cognitive and effective conscious state of awareness. So our speculation is that, is this linkage basically a neural substrate for chronic pain patients' common perception that pain becomes part of who they are, a core part of their self-referential state. So, you think of yourself, if you're not a pain patient, you don't think of yourself as somebody who's in pain. Whereas when you have chronic pain and you've had pain for a long time, the pain suddenly becomes part of you. And it can even sometimes become a barrier to healing, to not being a pain patient, because now you've internalized this pain and it becomes part of who you are. And of course this is wild speculation, but if we can somehow get at that get at that phenomenon, can we try to tie in this default mode network and insula connectivity with that phenomenon? And might this be, if we can somehow break the default mode network insula connectivity in these patients somehow, would we then be more effective in treating fibromyalgia with whatever therapy, be it acupuncture, be it something else? So another interesting phenomenon was that we found that this right executive attention network, which was more activated in patients than controls, was also correlated with the amount of pain that the patient was in at the time of the scan. So the greater the pain, the greater connectivity between this executive attention network and, again, the insula. So the executive attention network has been associated with working memory and attention. Fibromyalgia patients have cognitive deficits. But more specifically, these cognitive deficits appear predominantly in working memory and attention when different tests are made on these patients. And so these are particularly exacerbated with increasing distraction. Fibromyalgia patients have a very difficult time multitasking. They just can't do this. And cognitive deficits in fibromyalgia are correlated more with pain level than with psychiatric comorbidities. So that's been known from lots of review studies as well. And when we controlled for depression and anxiety in this patient population, we still saw this phenomenon of connectivity between the executive attention network and the insula. So the title is wrong here. I'm sorry. This should say EAN, insula. Anyway, speculation, is the executive attention network a neural substrate for the cognitive deficits seen in fibromyalgia patients? So the next bit of data to show you is what happens after acupuncture. In this study, we didn't have enough patients to separate out and compare real and sham acupuncture. So what I'm going to show you is actually a combined for real and sham acupuncture. And here, this is the protocol that was used for real and sham acupuncture, in these patient populations. And this study was actually run by my colleague, collaborator Rick Harris out at University of Michigan. And so the protocol was done as similar to clinical trials that he had run in the past in fibromyalgia patients. And what we found is that there was a diminishment of pain, both as assessed by the McGill Sensory and Affective Scale, in these patients. So this is now combined. You can think of it as pre-therapy and post-therapy. And we also saw a decrease in this increased DMN to insula connectivity. So after the successful therapy, there was a diminishment in DMN connectivity to the insula. And this, by the way, is this is a whole brain analysis. So this is the only part of the brain where we saw a diminishment in connectivity to the DMN. I want to stress that this is not some sort of masked ROI result. And we also found that there was a correlation with the more improvement there was in pain, the more decrease there was in DMN connectivity to the insula, although a slightly different location, as you see here, than in the past. So I'm almost done here. This is another interesting finding, and this is looking at sort of the biomarker of DMN insula connectivity. We also, in another data set at the Martino Center, evaluated low back pain patient, a different population of chronic pain patients, but also, I would argue, a functional pain population. And we evaluated them also with resting connectivity. And so it's a completely different data set, 6 minutes fMRI scan. And this is the correlation of the default mode network relative with the amount of pain that the patient was in at the same time of the scan. And we again found, I would say almost the exact same place, a correlation between default mode network and insula with the amount of pain that the patient was in at the time of the scan. The greater pain that they were in at the time of the scan, the greater the amount of DMN insula connectivity at rest. And we just sent this paper out yesterday, so wish me luck. What was, I think, even more interesting, actually, in this study is that we had the patients perform a maneuver where we were raising their legs. And this was done in order to exacerbate, short-term, exacerbate their pain, to make them more painful. So this is kind of the counterpart to the study you saw before, where we had a therapy to improve their pain, and we saw a change in DMN insula connectivity. Now we're doing the opposite. Now we're increasing their pain and looking to see, is there a change in DMN insula connectivity? And we found this really nice correlation with the amount of increase in pain to this provocation and the amount of increased DMN insula connectivity. So now we have both the improvement, the change in improvement, and the change in worsening of pain is related to this DMN insula connectivity pattern. So in summary, neuroimaging can be incorporated into clinical trial designs to explore potential mechanisms underlying clinical improvement. Different acupuncture mechanisms for different pathologies. So a local lesion, somatosensory neuroplasticity in S1 may be associated with acupuncture-induced improvement in peripheral nerve health and carpal tunnel syndrome. And a global lesion, quote unquote, functional brain connectivity and default mode network may prove to be an objective neuroimaging biomarker for chronic functional clinical pain and is sensitive to acupuncture analgesia and fibromyalgia. So thank you very much for your attention. I definitely want to acknowledge all my colleagues that helped with this research, especially Rick Harris and Dan Claw over at University of Michigan that were instrumental in the fibromyalgia study, and Joe Adet, who's my co-PI collaborator on a lot of the carpal tunnel work. And of course, Bruce Rosen, the head of the Martino Center, who's been very supportive over the last literally 15 years in acupuncture neuroimaging research at MGH. And of course, my funding agencies, without whom there's no way any of this research would be able to happen. So thank you very much. And I especially want to acknowledge my family, who's been very supportive over the years as well. And we have twin screens for my twins. Just noticed that. Thank you. Open up for questions. Please.
Were all the patients treated drug-free?
In which study?
Oh,
In the Bow study, we did not wean them off their drugs. We did not want to mess around pharmacologically, so whatever drug they were on, they were told to stay on that drug. So if we're doing a post and pre comparison in a longitudinal study, theoretically they should be on the same pharmacological dose in both of those scans. Yes?
You define your patients for the carpal tunnel very strictly, so either the manifest was positive or negative. That was your criteria for the carpal tunnel. Do you have similar criteria for your fibromyalgia patients?
Yeah, I mean, it's very controversial. We did use a criteria. So Dan Claw is one of the, I guess, world experts in fibromyalgia research. And the criteria change actually very recently, I think, or there's a push to change the criteria. But for that study, we used the old criteria, which are these 18 pressure, 18 points, and you have to have greater than a certain number of points to be sensitive in order to, I mean, it's a very subjective criteria, actually. And
Many of the polls, sort of like people thought they had carpal tunnel, but they didn't. Did you have a lot of patients that had fibromyalgia, I mean, they thought they had fibromyalgia, but they didn't?
Well, we don't know. There's no objective criteria. The reason I say false is because there's actually an objective measure with this nerve conduction slowing in carpal tunnel. There's no such thing in fibromyalgia. I don't know, maybe some neuroimaging marker will become this objective marker for fibromyalgia in the future, and we can talk about false fibromyalgia patients. So, yeah. I don't know. Sure.
Margaret Naser used laser acupuncture for carpal tunnel syndrome, and I was just wondering, have you looked at what the result on the EEG is from coherent light as opposed to a needle?
On EEG?
Yeah.
EEG or EMG?
Both.
Both. I'm definitely familiar with her work. I would probably guess that there might be different mechanisms happening in that type of treatment than with, we're sort of opposite ends of the extreme. In her treatment, it's subliminal. The patients aren't going to feel anything. In the treatment that I'm talking about here was electroacupuncture with a needle going in right here. So you're talking about opposite ends of the extreme. Yes, I mean, she didn't look at brain imaging. So it's a good question. It might. Oh, if I had, no, we've never looked at that particular treatment. But I would argue that if there's an improvement in nerve conduction velocities and there's an improvement in symptomatology, I wouldn't be surprised if there's also a change, in the brain, because I think the brain is a kind of a distant readout of what's happening locally in something like carpal tunnel syndrome. So if the milieu changes here, if something about it changes over here, and you have a decrease in symptomatology and an improvement in nerve conduction, then theoretically you should see a concomitant improvement in the brain. Yep.
Can you speak to whether, from a clinical perspective, after you're done and you get the improvement changes, how long might those last, or does it?
Yeah, that's a very good question, and we're asked that all the time by clinicians, and rightfully so. And so in the study that we're doing now, we do have I believe, a 3-month and 6-month follow-up that we're doing. So hopefully we'll be able to answer that.
Just looking at the carpal tunnel studies, one of the things also in carpal tunnel is an anesthesia. And when we talk about the central representation of sensation, it requires that you actually have intact sensation peripherally, so that you control for the loss of sensation in the distributions that were studied. Because if you were to improve conduction by any means, you would improve central representation and recognition in terms of two-point discrimination or recognition location. And so the distribution on S1 could merely be an improvement in terms of peripheral conduction and a better identification of where you're being stimulated. So it was a couple of things. Is there a control for limb temperature, which will change conduction in a short term? And additionally, the thought of the possibility of just a change in terms of peripheral diffusion in terms of changing the conduction in that.
Okay. Yeah, a few questions there. So let me take the easy one first. With the temperature, we did not control for temperature. In the current study, we are recording all the temperatures. We're looking at that and looking at potential correlations between change in nerve conduction velocities and change in temperature. And also we have control groups. If you notice, we didn't have a control group in our original pilot study. So hopefully we'll be able to account for all that. You're absolutely right. If there was some sort of systematic bias in the temperature of the palm, from the final versus the baseline evaluation, that could help explain some of the changes in conduction velocity. But keep in mind that conduction velocity was not taken in the scanner. It was taken at a completely different visit. And so in a temperature-controlled environment in the scanner, which is probably more temperature-controlled than the room that the clinical evaluation was happening in, I doubt that would be an influence on the brain imaging results. That's due to a temperature changing?
Is there any evidence that you change limb perfusion peripherally and particularly sort of at the surface where you're testing spontaneous innervation?
I'm trying to think why that would be, except for maybe in time that they're in the scanner. No, I don't see why that would be. It's the same environment. Why there would be a different? We didn't record it, so I can't. It's just pure speculation if I say anything.
In terms of any quantitative sensory testing on the limb.
Yeah, I think in the pilot study we looked at two-point discrimination, and we're not doing it now. It was like too variable of a measure. We're taking patients that our inclusion criteria was mild to moderate CTS. We are not looking at severe CTS. If there's some sort of frank deafferentation, if there's atrophy in the musculature, if the nerve conduction velocities are beyond a certain range, we send them straight to surgery. We don't fool around with them. So we're trying to treat mild to moderate CTS, not severe CTS. But at the same time, I don't see a disconnect. If there's an improvement in two-point discrimination or an improvement in a nerve block, and so you have better, more regulated nerve traffic now coming from the fingers, you would see an improvement in brain response. I don't disagree with that at all. That's, I think, is what's happening. Yeah.
I have two questions. One is on a CTS study. If the study people are mild to moderate, is the response you're getting from acupuncture basically exactly the same response you would see in people who responded to medication?
Medication? What medication?
Anti-inflammatory.
There was a recent.
About the mechanism from the
It's a hypothesis. I mean, if the brain results are truly just kind of a brain readout on what's happening locally, and if you can use anti-inflammatories, which is a big if, to reduce inflammation and improve symptomatology in the wrist, then theoretically I would see the same thing with anti-inflammatories. It's something that could be tested. There was a recent fairly large and clinical trial out of Taiwan comparing acupuncture with some sort of anti-inflammatory therapy. I don't know if it was injection or it might have been, I don't think it was oral, but it might have been, and which showed that acupuncture was more effective, I think, than the inflammatories in treating carpal tunnel syndrome. But
Is on the fibromyalgia patients, is there a correlation between the length of time of suffering fibromyalgia and the increase of the DMN insula?
yeah, that's an interesting question. It's really hard to get at because it's self-report. I mean, fibromyalgia a lot of times is not evaluated. It's hard to look through notes. You're just asking somebody, yeah, I think I've had it for 30 years. Yeah, I think I've had it for 20 years, 20 months. It's hard to get at that, but it's a good idea. Yep.
Thanks for your talk. One of the obstacles that patients with chronic idiopathic pain have for compassionate care is a sense that it's not real, and your studies actually speak to that. And one aspect of that in the face-to-face encounters, facial expression of pain, objective behavioral modulation of affect. So I wonder if that was included in any of the pre-post studies, since there's often an impression that a patient who may smile and have a kind of reasonable modulation of affect, that this is something else.
I don't know the research on that. I don't know how good the data is on facial expression being an objective measure of the amount of pain that somebody's in. I work in clinically, I'm in a tertiary pain clinic. I see some pretty severe pain patients that come in with a smile on their face and they tell me that they're at 8 out of 10, 9 out of 10 pain. I'm like, how are you smiling if you're in an 8 out of 10, 9 out of 10 pain? And it's not unusual. I've talked to colleagues over there too. They say that they see that all the time. And I don't know. I just don't know the data on that. But it'd be great if we had some sort of objective marker of pain. I mean, people have been looking at that as dawn of pain research. Yep.
Since this is part of the integrative conference, you talked about insula at the end. Insula has been a focus for interpersonal neurobiology and attachment, and mindfulness meditation changes with that. So could you speculate a little bit about how that might be an area of integrated treatment?
Yeah, I mean, it was a little cursory, my treatment of the insula. I mean, I refer to it as a part of the brain that is important for pain response, and in, say, translating discriminative to affective dimensions of pain. This is true, but you're absolutely right. The insula is much more than that. Bud Craig even posed the hypothesis that the insula is the seat of consciousness. I mean, it seems to be activated in so many different studies. So, I mean, we're definitely seeing this phenomenon. I believe this phenomenon, we've seen it in different populations of greater insula connectivity to the default mode network. But exactly what that means and what's the inference on that, I don't know yet. I don't know yet.
Did you look at the cerebellum in all of these?
Well, the cerebellum is being imaged. This is whole brain evaluations. So we looked at the cerebellum. It pops up here and there, but nothing consistent. Yep.
Just linking to what Brian said, studies of mindfulness have shown that people who meditate move out of the default mode network. And maybe it's the linkage of the default mode network and the insula together.
Yeah, I mean, maybe. Yeah, the question was that in mindfulness studies, people have shown that, I'm just paraphrasing here, that they can move out of the default mode network using the insula, and might this DMN insula connectivity be important for, say, I guess other, and I'm inferring here, other integrative modalities, other CAM modalities, other. Right. But not more pain, exactly. So maybe it's a specific region of the insula. I mean, we don't want to look at the insula as one unified entity. It might be specific subregions of the insula and their connectivity to networks such as the default mode network that might be important as well. Yep.
Did they have any other modalities that would change, like just bracing, use repetitive exercise, birthplace changes?
No, we told them to maintain whatever, when they came in at baseline and they're doing whatever drugs that they're on, whatever splinting that they're doing, whatever, everything else they're doing, we wanted them to maintain that throughout. We asked them, and at least in this study right now, we're probing them to make sure that they're not changing their other. But it's difficult, right? Because let's say they're getting better, then they're going to say, well, I'm getting better. I don't need to splint anymore. So I'm going to stop wearing my splints, and then suddenly my pain's going to get worse. So it's a difficult thing, I think, for them to try to keep them on schedule. Good? Well, thank you very much.